The next lecture forces me to remind everybody that COVID is here and tell you that the speaker couldn't come because of it. It's Chris Schlachta. But before I talk about him, I'd just like to say that this session, the co-chair should have been Leanne Feldman, who is our current president. And she was the chair of the RPS committee that, as I said at the beginning, this session started. Then we miss both of you if you're listening to us. Chris has sent us a recorded lecture. Chris is a professor in the Department of Surgery and the Department of Oncology at the Schulich School of Medicine and Dentistry in Western University. He is the medical director of CSTAR, that's the Canadian Surgical Technologies and Advanced Robotics at London Health Science Centre. He has a tremendous imagination, and he has led innovation in SAGES during my presidency year, and I'm very grateful to him for it. Could we put the video, please?
Well, good morning to all of you in sunny Las Vegas today. I apologize that I'm unable to join you, and I look forward to seeing you all again soon. I would like to start by thanking our program chairs, Dr. Tellem and Al-Saidi, as well as our presidents, Drs. Asbin and Feldman, for the invitation to speak today. So let us together try to reimagine the OR. I have nothing relevant or not relevant to this talk to disclose today. There are a few things that are relevant to reimagining the OR that I want to acknowledge today, although I will not be discussing them. The first is where surgeries will be taking place. Inpatient procedures now make up less than 20% of all surgical cases, and ambulatory surgery centers account for the majority of the ambulatory surgery market, with anticipated growth continuing. Surgeons are more commonly equity shareholders in ASCs, which is helping to drive the surgical innovation, but also refocusing the discussion around the fiscal constraints and value add to these new innovations. Women now make up greater than 50% of medical students in the USA and Canada. The face of the surgeon is going to continue to evolve over time through the efforts of many, including this society, to facilitate racial and gender diversity. The evolution of biotechnologies will change our practice in ways we can and many we cannot yet foresee. This will include advances in precision medicine, and many diseases will lose their association with the scalpel. Similarly, extracorporeal and external beam energy sources for manipulation and ablation will alter what requires a knife, but may well remain within the realm of surgical practice. So let us focus on surgical technologies, and in particular on computer-assisted technologies, because I firmly believe that any time we can insert a computer between the patient and the caregiver, we have the opportunity to enhance care. In just the last 20 years alone, computer power has increased by 100,000-fold. So it would be easy for me to say that in the OR of the future, surgical procedures will simply be performed by an intelligent robot. And perhaps as surgeons, we all need to learn to ask questions like, would you like extra foam on your latte? The reality is that those type of intelligent machines are still the stuff of science fiction. We are not likely going to see those in our lifetime or the next. However, there are three areas that are going to drive exciting surgical innovation in the coming years, and these areas are artificial intelligence, computer-mediated reality, and robotics. Artificial intelligence is the simulation of human intelligence by a machine, but it does not necessarily imply that the machine is actually thinking. In fact, one way of classifying artificial intelligence is to break it down into three categories: narrow artificial intelligence, general intelligence or strong intelligence, and artificial superintelligence. The latter two are beyond our capabilities currently. However, narrow artificial intelligence, where the decision-making processes are very strictly context-specific, which in itself is a very broad field, the beginnings of this are very much within our current grasp. The main way that computer intelligence has assisted us throughout the decades has been through classical programming. This is just a brute force approach where we provide data and an algorithm and the computer generates the answers in the way that we have directed it to do so. With machine learning, we typically provide the computer with lots of data and the outcome that we're looking for, and we ask it to determine the rules of engagement. This is often an iterative process that requires human intervention for correction. Deep learning is a subset of machine learning in which multiple layers of a neural network are employed, in what we think might be similar to the way humans think. This process is also iterative, but the deep learning machine learns from its own mistakes and is self-correcting. Most significant is that the deep learning machine requires vast amounts of data input on which to ponder. This is why the accumulation of surgical data sets are so important. We often talk about the experienced surgeon. This is the one individual who has learned from his or her own experience over a limited career. And while we doubtless have to find ways to manage patient confidentiality and HIPAA compliance, imagine a world in which thinking machines don't just benefit from their own experience, but through an interconnected globe can learn from the experience of every surgeon performing every surgical procedure. In the world of deep learning machines, data is the new gold rush. For the last several decades, developments in visualization technology have focused on providing higher quality, higher resolution images. Only now are we beginning to truly harness the ability to manipulate those images to enhance surgery. In a world of computer-mediated reality, the reality-virtuality continuum begins with the real environment and extends into the world of virtual reality. Most of you, I would assume, are familiar with reality, where the world of virtual reality has clearly been driven by the development in video game technology. Between these two lies the world of mixed reality, where computer-generated elements are overlaid on our view of the real world, or alternatively, real elements are overlaid on the virtual environment. We already live in a world of augmented reality, where our smartphone can overlay computer-generated elements on our view of the real world. And similarly, many of us have already adopted augmented reality in the operating room in the form of near-infrared fluorescence imaging, where the fluorescence is detected by the computer and a computer-generated image, be it green or blue depending on your technology, is overlaying that image on your viewing screen. The other dimension of mediated reality is modularity, in which specific elements of your computer image can be manipulated. In modified reality, specific elements of your real world can be manipulated in a way that perhaps enhances visualization. Take this example of a robotic-assisted prostate resection, where identification of critical vascular structures will aid the surgeon in reducing blood loss and maintaining clear visualization. A modified reality image can enhance the pulsations of the vascular structures, facilitating their intraoperative identification. Diminished reality involves the removal of visual elements that could be distracting or unnecessary for the procedure being performed. Of course, a combination of all the components of these two modalities is possible. Consider, for example, where one is performing an intracardiac procedure using virtual reality guidance from a model that was developed by a preoperative dynamic CT scan and registered intraoperatively using ultrasound. Once access to the heart has been obtained, then the rib structure is no longer necessary, and a diminished reality environment in combination with virtual reality can remove those unnecessary components of the image and allow the surgeon to focus on the necessary procedure. So now let us discuss robotics. Depending on your definition, robotics has been with surgery for some time. For those of us in our specialty area, the evolution of minimally invasive, multifunctional, soft tissue robotics seem to be more focused on market share rather than technology development for the first almost 2 decades. However, we have seen a fairly recent, rapid cladogenesis in technology. The market thus far has been dominated by multifunctional, large platform systems, and there are many vendors who see a business opportunity in taking on the juggernauts in this area. Once again, market forces and technology development have facilitated speciation into market opportunities for a wide range of new robotic technologies, including single-purpose robots and miniaturization. We continue to see the evolution of handheld robotic systems, but also new non-linear technologies that are facilitating access to harder to get at regions of the body, including endoluminal robots and single-port robots, to name a few. Let us take a few moments to talk about platform-agnostic robotic autonomy. This is something that was covered very well in this article published 4 years ago, but that is still very relevant today. In this piece, which was published by robotics experts and engineers, one of whom I might add is my collaborator and director of engineering at CSTAR, they lay out a classification system for the future development of robotic autonomy. At the high end of this scale are true robotic systems that can sense, think, and act with a high level of autonomy or full automation. These are systems that, although they would still be technically classified as narrow artificial intelligence because they would remain context-specific, they are still well beyond our capability for some time to come. Of course, we are all familiar with non-autonomous robots, so-called master-slave systems, because these have made up the predominance of surgical robots for the last 2.5 decades. In fact, many would argue that these don't qualify as true robots and rather are simply mechatronic devices. Similarly, many of us are already quite familiar with using robotic assistants. Technically, every time you pull the trigger on a powered stapler, you are activating a robotic system. Task autonomy is an area of surgical robotics that I think is actually well within our grasp. This is where we give the robot an opportunity to perform repetitive procedures that it can do with more precision and perhaps less fatigue than we can. For example, consider a system that affords task autonomy with knot tying. We place a suture, we precisely take bites with our needle, and then we align the tail of the suture in the predetermined configuration. At this point, we then push the knot tying button and the robot puts down the throws of the suture for us, precisely with the appropriate amount of tension, no breaking of the suture, and less fatigue on the operator. A world of conditional autonomy is actually a much more exciting proposition and something which is medium-term achievable. These technologies, but for regulatory considerations, are already available to our colleagues in orthopedic surgery and neurosurgery. The rigid structure of the bone or the rigid containment of the brain makes preoperative planning with intraoperative image registration much more achievable for non-soft tissue robotic systems. The less predictable nature of soft tissue makes conditional autonomy robotics much more challenging under these circumstances. However, we are seeing significant advances in imaging technology and artificial intelligence, which is going to bring this all into play. So let me offer up for you one vision of the medium-term future of the operating room. We begin with a patient whose medical condition requires surgical intervention. Now we bring in our dedicated, capable, caring, and compassionate surgeon who will attend to this patient. We insert our computer system between the two because anytime we can put a computer between the patient and the caregiver, we have an opportunity to improve the quality of care. Now our computer system scans our patient with superhuman sensory capability and uses that information to construct a patient-specific virtual reality simulation that employs mediated reality to augment the identification of vital structures and focus on the critical elements of the procedure. Now that simulation is presented to our surgeon at an ergonomic surgical workstation where they can practice and perfect, or in surgical terms, debug the planned procedure for our patient. The procedure plan is then uploaded to our robotic system where it is executed effectively and efficiently under our surgeon's supervision. This will have a dramatic impact on quality, safety, and efficiency in the use of what has become a highly valuable commodity, access to the operating room. This is all but one possible, even inevitable future as we continue to evolve and adapt remarkable technologies into our reimagined OR of the future.